Hi everybody, my name is Mark Scholes. I'm a lecturer here in the discipline of physiotherapy at Trobe University, and I teach into the postgrad Master of Sports and Exercise Physiotherapy and Master of Musculoskeletal Physiotherapy courses. I'm joined here today with Dr. Michael O'Brien, and Mike and I are going to talk about hip pain. So Mike, I'll just pass over to you and let you introduce yourself.
Hi everyone, my name is Michael O'Brien. I am a postdoc researcher here at La Trobe as well. I'm a physiotherapist. I work clinically at Mog Sports Medicine as part of the Hip and Groin Clinic, and am working on some hip dysplasia projects here at La Trobe.
Good on you, Mike. Hey, so obviously you treat a lot of patients with hip and groin pain. That's the main focus of your clinical work. Hip and groin pain has been called the Bermuda Triangle of sports medicine due to the complex diagnoses in the area, and often patients will present with overlapping clinical entities. Do you have a strategy or a structure that you approach diagnosis in your patients with hip and groin pain?
Yeah, great question. I think at its simplest, I try to differentiate whether I think that person's hip and groin pain is intra versus extra articular. So I think obviously there's other sources that can be involved as well, such as your lumbar spine or your pelvis, where it might be referring from. But I think trying to establish, is the primary cause of their pain and their condition something of intra-articular origin, or is this more a soft tissue tendon issue that's coming from outside of the hip joint? What about you?
Yeah, so equally. So do you think about, like obviously within the hip joint, there's many different diagnoses, like often patients will present with MRIs with labral tears and chondral pathology. How do you differentiate those versus potentially other sources of intra-articular hip pain?
Yeah, so I think that's such a good question, because we know from like Josh Herrie's work that intra-articular changes such as on MRI, cartilage defects, labral tears and things are actually really common in people who don't have pain as well. So I think often if we go looking for intra-articular pathology, such as on a scan, and sometimes patients will turn up and all they've had is an MRI scan, it's very easy to go down a path of intra-articular diagnosis based on MRI findings. I think having an appreciation of the underlying morphology is really important, particularly in hip-related pain, to know whether there is some underlying hip impingement or hip dysplasia that is causing some type of restriction or excessive movement in the hip joint that might then be part of that condition.
Yeah, I think I'm thinking about the bony morphology as well. Like often, as Josh's work in terms of intra-articular pathology, when we think about the bone shape itself, like when we think about FAI syndrome or hip impingement, we often think about CAM morphology. And so again, CAM morphology is really common in people like with and without symptoms. So is there a way that you, I guess, talk to your patients about that, and how much emphasis do you place on the presence of that bone shape when the patient comes to you?
Yeah, I think making sure that you set expectations when you refer for imaging about what you might expect to see on the result of that scan is really important. So obviously if you're going to refer for imaging, you're going to have a little bit of an idea of what you're expecting to see, what you're wanting to find, or what you're hoping to exclude. But then I think also giving that patient information about, don't be alarmed if on that result or on that report of that scan or that x-ray that we might see a bit of this, or we might see some intra-articular changes, particularly in patients kind of, I don't know, anywhere upwards of 30 years old. You're likely going to see some signs of kind of wear and tear or degeneration. Obviously the terms that we use are really important, kind of wrinkles on the inside. It's really important to try and not get patients too alarmed about some of those findings that they might find.
Yeah. So if we go back to this idea of diagnosis and categorisation of hip pain, so we're just chatting then about, so obviously FAI syndrome or hip impingement is one, and that has a distinct kind of bony morphology or bone shape, and CAM morphology being the most common. The second category that often will or has been recommended to be used in clinical practice is this idea of hip dysplasia or hip instability, and those two obviously have that distinct bone shape. And then that third category being like intra-articular pathology without those specific bone shapes. And so as a broad like construct or way to categorise patients with hip pain, like I think in my clinical practice I find that really useful to sort of navigate through all those different diagnoses and the complexity around those diagnoses. So thinking about, like, obviously hip dysplasia for you is a big part of the research work that you do, and also the clinical practice that you have. Can you define exactly or describe exactly what hip dysplasia is?
Yeah, absolutely. So I think, well, I say yes, absolutely, but I actually can't, because there's not really any international kind of consensus on what the diagnosis for particularly adult hip dysplasia is. There's some kind of descriptions out there that I think are really helpful in how I conceptualize the condition. So if we think about one of the descriptions that I quite like is this loss of conformity between the femoral head and the acetabulum. And that could be due to changes in the shape and or the size and or the orientation of the hip socket. So is it the way that the ball and socket is facing? Is it a deficiency in the socket, which is, I think, historically how a lot of people have thought about hip dysplasia. And so any kind of changes to any of those structures or orientations, I think, is a nice way to think about hip dysplasia. Obviously, if you use that as your description, though, that does somewhat encompass FAI. So I think on the spectrum, a lot of people will think about FAI and hip impingement as being on this kind of stiff side of the hip, and then hip dysplasia and instability being obviously towards that other end of the spectrum. So I think conceptually that can be helpful to think about as well. Nothing super kind of black or white in terms of, again, diagnostic criteria, but we'll talk a bit more about kind of what I use clinically and what many people use clinically. But as a description and as a way of thinking about this, I think that can be helpful.
And so in terms of prevalence with hip dysplasia, particularly adult hip dysplasia, how common is it? Let's start there.
Yeah, so a lot of the prevalence data, again, because there's no consensus on diagnostic criteria, it really affects the prevalence data, because then this population in this country is looking for prevalence, but they have a different criteria to this country in this part of the world and how they diagnose it. And this can be from the angles that they use, from the cutoff values of those angles that they use, and literally from where they measure some of those angles. So there's a lot of variation in there, anywhere between kind of 3 to 20%. But I would say most of the studies would report a prevalence anywhere between 4 to 6% of the general population. Interestingly, I think when you look at some of the research where they look at people with hip pain, and I think that immediately becomes a lot more relevant to us as physiotherapists and clinicians, because what proportion of people are coming in with this condition? Because by the time they come to see you, they've obviously got some form of kind of pain and symptoms, and it's about a third. It's about a third of people who come to see you have changes or dysplastic features on X-ray. Now, that's not to say, as we talked about before, asymptomatic findings. That's not to say every single one of those patients is having their pain because of their hip dysplasia, but we see dysplastic changes in about a third of patients who present to primary care with hip pain.
Yeah, it's super interesting in terms of the mechanism by which this the hip dysplasia is happening and developing over time. So often physios and often patients will think about hip dysplasia being a purely pediatric condition, and we think about infants being braced for that. Do we think, or do you think that that this adult hip dysplasia is potentially young children that have been missed in that screening process, or is this something that is still developing through their early years?
Yeah, such a good question. So I think, obviously, there's even been a change in the name, right? So traditionally it was congenital hip dysplasia, and then that term has changed into developmental dysplasia of the hip more recently, and that has, my understanding is for two main reasons. One is that to encompass the people that may not necessarily be born with hip dysplasia, and obviously in places like America where you can be sued if you misdiagnose someone, it was a way of actually covering them legally as well. So let's change the name so that people can't necessarily say that everyone with hip dysplasia was born with it, and some people may have developed it later on. I suppose an early example, you may not be born with it, but it can develop during infancy still. So swaddling, for example, is a big risk factor that has been shown to be associated with infants with hip dysplasia and those without. So being swaddled in an adducted, kind of extended position, like tightly bound, has been shown to be associated, as opposed to a more flexed, abducted, externally rotated position. With the theory there being that you're putting the ball of the hip joint, so the femoral head, deeper into the acetabulum, and over a time that's going to deepen the socket, as opposed to the infant who is in a more adducted, extended position. And then there are thoughts as well, and I think as you get older, the research probably is less strong in some of these different categories, but young athletes who potentially do a lot of end range of motion activity. So we're thinking gymnasts, ballet dancers, lots of rhythmic gymnastics, things like that, where you're taking the hip joint repetitively to end range of motion, is thought to potentially have an effect on the growth of the acetabulum as well.
And that potentially explains that the development of these conditions, maybe not necessarily from an infant stage, but through those early childhood years.
Absolutely. And I think once we're reaching bony maturity and those growth plates have closed, so we're thinking kind of mid-teens for females, maybe a couple of years later for males, you shouldn't theoretically be developing hip dysplasia at that point after that stage, unless it's been induced by potentially inappropriate surgery or something like that.
And I think that's analogous to FAI syndrome, where we know that once that growth plate in the femoral neck is closed, then the development of the cam stops. But it may take many years before that becomes symptomatic for the individual. But that bony risk factor has been there since like adolescence, effectively.
Yeah.
So we're chatting about kind of, I guess, how that develops. Can you talk about the particular bone shapes or orientations that you see in the clinic? So obviously you were saying before about the definition of of dysplasia being a misalignment between the femoral head and the acetabulum. Can you talk about the different orientations of the acetabulum that you see in clinical practice and how they present?
Yeah, for sure. So I think traditionally people have often always thought about hip dysplasia as just the shallow socket, right? And that is certainly a type of hip dysplasia that people see and that can present, but it is a little bit more complex than that, and there are some variations, which I think I've tried to show here in one of my slides. So I've got a video here where we've got the acetabular morphology, and you can see their normal version for the acetabulum and for the femoral neck. I like to think is roughly kind of 15 to 20 degrees. So they're slightly facing forward. So they are naturally in a more anteverted position anyway, if that makes sense. Both the structures are facing kind of slightly anteriorly. And then if we think about how that can change, so you can have excessive, if we think just about the acetabulum for a second, that can be facing further anteriorly. So that would be regarded as acetabular anteversion, but it's essentially excessive anteversion of that condition. And as you can see here in the video, so that can be turned forward. And what you're going to see here is an opening up of the space in the anterior part of the hip and a closing down of the space in the posterior part of the hip. You can see the lesser trochanter abutting the ischial tuberosity there, almost, in some way leading towards also maybe some ischiofemoral impingement. And then conversely, the acetabulum can be retroverted from that resting normal position. And that is going to give you less space at the front of the hip and more space posteriorly. And then obviously you can have that generally undercovered shallow socket where it's just not encompassing the femoral head as much as it would in a normal hip. And then if we think about the femoral morphology, so as I said, also normally facing forward that kind of 15 to 20 degrees. And similarly, that can change as well. So you can have this increase in femoral anteversion where that's facing forward more. As I said, opens up the space at the front, reduces the space posteriorly, and then femoral version, the opposite of that, where that femoral neck can be facing closer to zero, and that closes down the space anteriorly and increases the space in the posterior hip. And there's often other things that can occur as part of hip dysplasia as well. You can have coxa-valga, coxa-varus and things, but I think in its most simple terms, this is a really nice way to think about some of the changes that can commonly occur at the hip as part of hip dysplasia.
Yeah, it's really interesting that the retroversion in particular, Mike, often if we think about what that's doing in the front part of the hip, will be reducing space and potentially increasing the likelihood of impingement with the femur. So for you, is that an impingement condition? Is that FAI syndrome, or is that considered dysplasia in your clinical practice?
Yeah, such a good question. So I think, again, and some of it can depend on the clinical picture, right? So you almost move away from what the imaging is maybe telling you and kind of thinking, does this feel more like a stiff hip, or does this feel more like a hip with excessive range of motion? So one of the key clinical differences for someone potentially with, say, femoral retroversion to someone with cam morphology, both will give you potentially this reduction in hip internal rotation, right? They can provide that early block to that internal rotation. In someone with femoral retroversion, what you're going to have though is that increased space posteriorly. So you'll often see that coupled with increased external rotation range of motion when you go to measure it. And so someone who's got that excessive range of motion, either just into ER or more globally, or they're more that instability type picture, I would probably tend to think about that more as a hip dysplasia picture, and I'm thinking more of like a young female, and we know that femoral retroversion, there are some, I'd say not high level studies, but there are some studies out there that show that femoral retroversion can be associated with ballet dancers, for example. They spend so much time in turnout during those formative years, and that can affect their bony growth. That's the hypothesis. And some of the research has all it's shown, though they didn't do it with imaging, they just looked at the range of motion and found this increased ER, obviously, with ballet dancers. So in someone like that, I'm thinking more of a hip dysplasia kind of patient. In a young male that is playing football and doesn't have increased range of motion globally, I would probably think of that more as the stiff kind of impingement type picture. I don't know that it matters too much what you call it. Obviously, patients love to be diagnosed, and particularly if you're seeing a patient who's had pain for a really long time, they're seeing a couple of clinicians, they really want a clear diagnosis. So often you do try your best to kind of give them a word or two to classify and encompass their pain. But I do think for the sake of your own clinical reasoning, it's good to be more open-minded about the different factors that might be influencing their pain, and making sure you don't necessarily go all in on a specific diagnosis and just treat it as that particular diagnosis. Take into account their impairments, take into account the different, whether they have a CAM plus retroversion, and those things become more important, I suppose, more if they're failing conservative management and physiotherapy and you're thinking about onward referral, because that can affect who and why you might send them to someone, as opposed to with their physiotherapy. I'm not too sure that it's too important, particularly in that early stage.
And I think it's such a good point, like in terms of putting that whole picture together and not just relying on the bony morphology, but thinking about those subjective features from the case, but also your objective findings, which I think we'll chat about in a minute. I just wanted to close out this idea of imaging. So if you suspect your patient has hip dysplasia, are you routinely imaging them at that initial consultation?
Yeah, there's so many considerations that I take into account when thinking about whether or not I'm going to image someone, and I think I've got a slide on this that I'll leave up while I'm talking. So I think thinking about what that patient's been through before they've even come into the room with you, right? And I think, how many people has that patient seen? How clear do they feel that they have a diagnosis? If they don't have one, how frustrated are they by that? And I think we've all seen patients that have come in, that have seen a lot of people, that don't have a clear understanding of what's going on, and they're not getting any better. In that patient, I would have a very low threshold to image them and try and give them some confirmation on what's going on, and try and validate their experience and validate their pain through being able to highlight whatever might be going on. I think a big part of it for me is, are you getting better, are you getting worse, or are you staying the same? You know, those basic questions that we get taught in early physio school. Because if someone's already starting to get better when they've come to see you, I doubt that they probably feel the need to go on and go and spend money and time and resources getting that imaging, as opposed to the patient who is getting no better or is actually actively getting worse. I think that is a big part of the picture of why I would decide whether or not I need to image someone, what they think is going on, what the quality of the physiotherapy that they've already had is. So have they just been lying down and been getting ultrasound on a machine that's turned off, or have they been in the gym doing really good strengthening work, and they've seen people that I know would have given them really good rehabilitation. Okay, well, I'm not too sure I'm going to add that much more to what you've already had, and I think you probably actually need to see somebody who can go through some other treatment options with you. And if I'm going to do that, I do think it's really important to have some imaging to confirm diagnosis. And if I am thinking I might send them to an orthopedic surgeon, for example, different orthopedic surgeons have different skill sets, right? And there are people out there who might only do total hip joint replacements, or only do hip arthroscopy, or only do PAO surgery. And so for me, I want to have a good idea of what that patient has before I decide who I'm going to send them to, because as well, obviously it would be nice if every orthopedic surgeon you sent them to would consider what is best for that patient, and if that wasn't in that skill set, if that wasn't in their skill set, they would send them off to somebody else. But in reality, I think we all know that that doesn't always happen, and sometimes that patient might have the treatment that is the only treatment that that particular orthopedic surgeon might offer. And so I want to take that into consideration when I'm deciding who to send them to, making sure that it's someone that I think will have the tools to address whatever it is I think that patient's problem is.
Yeah, that's such a good point, Mike. So if we think about our patient that's presenting to us and we're suspicious of hip dysplasia, are there certain subjective features from the case or sort of patterns of their presentation that are consistent with hip dysplasia?
Yeah, absolutely. So I think before they even come into, or as they come into the room, I think we know that hip dysplasia disproportionately affects females and women, both when we think about hip dysplasia at birth and in infants, but also much more likely to present as symptomatic, even when you take into account, so in a particular prevalence study, they looked at the actual prevalence being relatively similar between males and females, but females often being more likely to present as symptomatic. And so there's other factors at play that lead into whether or not somebody has symptoms, connective tissue, having hypermobility, all these other factors, the kind of loads that you're exposed to, hormones, pregnancy, genetic markers. So, but appreciating that the prevalence is much more likely, so around 80% of people who have hip dysplasia are women. So recognizing how I would think about it and how my my clinical mentor Andrew Wallace will always say, if it's a young female, think about it as making sure it's hip dysplasia until proven otherwise, and in a young male, thinking about it probably as being hip impingement until proven otherwise. But making sure you've kind of already got those thoughts in your heads of things that you need to exclude. You don't want that to necessarily lead you to that direct diagnosis straight away, but making sure you are taking note of things such as their age. So, obviously that's going to affect whether or not they might have some OA, things like that. Family history is a really big one. So not just thinking about, do you have a family history of hip dysplasia, because we know that hip dysplasia has a long history of misdiagnosis. On average, 5 clinicians over 3 years. In a recent study out of New Zealand, they found that people were having surgery for hip dysplasia. Half of them didn't have hip dysplasia mentioned on their radiology report or their imaging report. So it's still the common problem. So with that in mind, when you're asking about family history, also asking about family history of even just hip pain. Do your parents or siblings have this history of kind of having undiagnosed hip pain or total hip joint replacements, particularly early total hip joint replacements? Yep. We know that hip dysplasia has this really strong association with OA, much more than other hip conditions. So getting an appreciation of that is particularly important as well. Weird questions like birth order, are you first or second born? We know that that carries an increased risk factor as well. Being breech either at the time that you were born or at any stage during the pregnancy, and I'm always surprised at how many people actually know that they were born breech, but those can be important questions as well. Just get an appreciation of also milestones. So often you'll get patients who maybe didn't really crawl for very long, jump straight into walking, or struggled to sit cross-legged at school, or W-sat a lot, always had, or know that they had feet that turn in or turn out, and obviously that can give you a lot of information about the versions in your hip as well. So just asking generic questions around a lot of that. And then as we've already talked about, kind of the sports that might have been played during youth, as you know, with FAI, often that can influence CAM morphology development. Similarly, there are thoughts, as I've already touched on, about the acetabulum development as well. So get an appreciation of all of that.
Yeah, and we were talking before about clinical reasoning. In terms of the making sense of the different imaging and variables and orientations of the acetabulum, are there certain clinical patterns that seem to appear with different orientations, be that like anteversion versus retroversion? Absolutely,
and I think hip flexion is something that I think we screen for really well in terms of, you ask a patient what their aggravating and easing factors are of their hip, and then I think and often there are patients that will beautifully demonstrate everything that aggravates and eases their hip, and there are often those patients that we need to prompt and ask a little bit further questions. And I think as physios, we're very good at prompting flexion-based activities. Oh, what about squatting pain? What about pain with sitting? What about and is the pain at the bottom of your squat? Yep, tick, tick, tick. Okay, you've got this flexion-based pain, and this is sounding a little bit more like hip impingement. And as I said, misdiagnosis is a big problem in this population, and often it is a diagnosis of hip impingement that they might be diagnosed with. I think what we could be a lot better at is screening for extension-based hip pain. And I might have a slide on this as well. So looking particularly at activities like walking, particularly that back leg while you're walking. So when you're going into that terminal extension position, and we know from research that both in hip dysplasia and in hip-related pain in general, as you know, that people often walk with reduced peak hip extension angle, and that can be in this population more to do with kind of anterior apprehension potentially, like you see in the shoulder. You don't want to go into too much hip extension, and you don't want to lever out the front. So making sure that we ask about prolonged standing, standing in high heels, walking, which part of the walking is it, and screening those extension-based questions I think is really important.
And do you use that, like those subjective sort of profile like that in terms of the direction of their aggravating factors to then guide your objective assessment? Like is that the positions that you want to test in? Yeah,
absolutely. So I think much like I think we've traditionally had this preference for flexion aggravating factors, I think we also have this preference for flexion-based special tests, right? We do a lot of flexion, we'll do the Faber test, we'll do the flexion adduction internal rotation test, the flexion adduction external rotation test, and I think a lot of people will have this part of their objective assessment, and again there's not a lot of extension-based provocation tests. And there's a few out there that are published, we need to do much more research in this area, but I think it's important that in your objective assessment you have some kind of extension-based provocation test to see if extension and or external rotation, again similar to what you do in the shoulder, reproduces any pain or symptoms or feelings of apprehension.
And are the pain provocation tests that we have useful at detecting these things, or?
Yeah, so I don't think any of the tests are great in isolation, and I think much like we would use for other conditions as well, it's about having a battery of tests that you put together with your subjective findings. Sometimes, we know that the FADER test, the flexion adduction internal rotation test, highly sensitive. So it is of clinical utility, because if it's negative, you can often rule out hip joint related pain. But if it's negative, but if it's positive, it really doesn't tell you much. It really doesn't change the picture. So you need to use a lot of different tests and put together that clinical picture through a combination of tests, subjective findings, objective findings, and potentially some imaging if you have access to it.
And so if we're thinking about, like, once we get to the end of our objective assessment like that, we have an understanding of their range of motion profile, we have an understanding of what things or what positions aggravate them. We've got a bit of an understanding of their baseline strength measures. Where do we go in terms of treatment? Is there evidence for conservative-based management in these individuals?
Again, not a lot of research. Not a lot of research done in this area in general. So I think when we compare it to obviously the knee, where there's so much research done, and then even we compare it to hip impingement, which I think we've known about, particularly in the physio and the sports medicine world for a while now. Hip dysplasia is well behind. And so we're only just starting to get there, particularly with non-surgical kind of treatment and management strategies. There are some recommendations for hip joint related pain in general, and obviously that consists of often hip strengthening exercises, movement pattern retraining, and we'll often see this kind of sway standing posture in people with hip dysplasia, and correcting that can be really helpful. I think activity modification in general can be really good in hip-related pain, and particularly in hip dysplasia. As we've mentioned, so in hip dysplasia, they can often have this increased hip joint range of motion, and I think taking your hip repeatedly to end range of motion can be highly irritable in this patient. So thinking about the different positions you might be sitting in, keeping people active by doing things like squats and deadlifts in the gym, but maybe not going into as much end range hip flexion and extension or range of motion can be really helpful. Educating on the amount of pain that can be useful and not useful when they are exercising, so you can try and keep them active, I think can be really helpful in terms of all the non-surgical management strategies. Absolutely.
Where do you stand on your patient exercising in pain? So thinking about these hip-related pain and hip dysplasia patients that are often really irritable.
Yeah, such a good question. I think if someone's in like an acute amount of pain, then trying to make sure that and kind of that inflammatory pain pattern, addressing that first. And I think that might be through activity modification, more simple, gentle exercises initially to try and settle that down, making sure they don't have too much night pain or pain first thing in the morning. And I often teach them around those are the signs that you need to be careful about. If that is getting worse, then we need to have a discussion around modifying the exercise and the loads that you're putting in your hip under, because we want that to settle down so that you're able to then actually increase your strength from the exercises as opposed to just being in more pain.
Yeah. I think it comes back to what you were saying earlier, Mike, about patient-centered care and really strong clinical reasoning. So using all of those bits of information from your subjective, whether it's including that with your imaging, and then obviously using your objective assessment to develop a really patient-centered, focused intervention and individualised intervention for
Absolutely.
your patient. Because given, like, as you're saying, in terms of the limited knowledge from the literature about what treatment pathways are optimal, I think we need to tailor our treatments to our patient as best we can. I think you've given us some really nice insights about how to do that from a subjective and from an objective point of view today. So thanks so much for joining us, Mike.
Thanks, Mark.
Appreciate it.